nodules, touch briefly on autonomous functioning nodules, and then quality of life outcomes. So the two most accepted indications for thermal ablation of thyroid nodules remains non-functional benign thyroid nodules that are symptomatic of patients, and then autonomously functioning thyroid nodules. And really, there's a plethora of percutaneous thermal ablative techniques that you can use. And which one is ideal for your nodule really is going to be dependent on the characteristics of the nodule. So purely cystic thyroid nodules, epidural ablation is a really effective and cost-effective thermal ablative technique, percutaneous ablative technique for those. But once the solid component of the nodule increases, you're really looking at thermal ablative techniques, of which radiofrequency being the most popular. So there's really, we all know that there are various advantages that are conferred by these percutaneous ablative techniques as when compared to surgery. And the biggest well-known is that these percutaneous thermal ablative techniques really do provide excellent volume reduction, right? And this is an early systematic review and meta-analysis that compared laser and radiofrequency ablation and really demonstrated that at about 12 months, you're looking at an average of about 63% volume reduction. And this is durable for about 3 to 4 years following that. Since then, there has been a tremendous amount of literature and evidence that confirms this, with some studies showing even greater volume reduction as you progress in your learning curve. The second advantage is that this is truly a minimally invasive technique, and you can do this in the outpatient setting. You get to avoid general anesthesia. There's really very little recovery time with these techniques, and patients do get to avoid a surgical scar, which remains a pertinent concern for small subset of patients. But perhaps the greatest advantage, and in my opinion, the greatest motivator for adoption of these techniques in the United States remains preservation of thyroid function. Patients really, I think, increasingly dislike the idea of removing an organ that is functioning perfectly well that's not cancer, only to replace it with medication. And so they are increasingly seeking alternative methods of treatment. And RFA is really good at preserving thyroid function. We do know that because some subclinical dysfunction with these thermal ablative procedures, almost always patients will be subclinically hyperthyroid within the first week or two post-ablation. And this is our data that we just published recently in the EJS that looked at sort of long-term trends. And patients always want to know, is their thyroid function going to be affected? And in fact, we do see a rise in the TSH that seems to peak at about 3 months post-procedure that then sort of normalizes. Almost always patients this happens subclinically, we don't really feel the difference. We also see a rise in thyroid globulin antibody and TPO antibodies. And there's, I think, increasing literature as well that these thermal procedures do induce an immunogenic effect. What the consequences of that long-term immunogenic effect is, we don't know and needs to be further clarified. But almost always those antibody elevations do normalize over time as well. So in terms of sort of systematic reviews of clinical outcomes for benign thyroid nodules, the recent ones that many of them have done. This is probably one of the more comprehensive ones that was published in Thyroid in 2022. In the study, they included over 4,000 patients from 16 studies. They evaluated all of the thermal ablative techniques, RFA, microwave, laser, as well as HIFU, and compared it to conventional surgery, which doesn't always occur. And they did a network meta-analysis and used the Sucre method to actually rank amongst the methods which one was best to achieve which outcome. And they evaluated a pretty comprehensive panel of outcomes in this study. So with regards to volume reduction ratio, which is our objective measure of technical success, all 16 studies were included in here, again, over 4,000 patients. And this is the network meta-analysis diagram. For those of you guys who are not familiar with reading these, the circles generally represent the number of patients that are included in the analysis, and the thickness of the lines actually represents the number of studies that compare the two methods. Okay, so you're going to see the greatest comparing laser and RFA and microwave and RFA. This is the super plot, which is basically just a mathematic representation of the ranking. And it's important to note for this study that they defined conventional surgery with a VRR of 99% confidence interval of 98 to 100%, which I think is a fair definition. So, not surprisingly, when it comes to volume reduction, surgery came out best. You would certainly hope so, as a surgeon. But amongst the percutaneous techniques, although they were not significantly different, RFA did come out as the best percutaneous thermal ablation technique to achieve the best volume reduction score with a super score of about 63%. When it comes to symptom and cosmetic scores, generally 5 studies were included. This only included the thermal ablative techniques of RFA, laser, and microwave. Over 2,000 patients. These are the super plots. And essentially, laser and microwave actually came out slightly higher than RFA for symptom score, but microwave came out as the best super score for achieving the cosmetic score. Although, again, from a statistical standpoint, there was really no difference between all 3 techniques. This is going to overlap a little bit with Imad's talk coming up, but they did evaluate vocal complications as well as transient current laryngeal nerve injury. And here is the meta-analysis network plot, and here they compared it to conventional surgery. And they found that RFA and microwave were superior to conventional surgery when it came to vocal complications. Amongst the percutaneous techniques, there really was no difference, except when you compared RFA to HIFU. Interestingly, HIFU was associated with vocal complications. Okay. And then when it came to recurrent laryngeal nerve injury, compared to surgery, both RFA and microwave were superior to conventional surgery, which is not too surprising. But when compared to HIFU, actually RFA had less transient recurrent laryngeal nerve injury. In terms of thyroid dysfunction, 6 studies were included here, over 2,000 patients. And when compared to RFA, we switched up the analysis this time, conventional surgery was not as good. Also not surprising, and there was really no difference with microwave. But Supra did rank RFA as the intervention that was least likely to result in thyroid gland dysfunction with a pretty high Supra score. And then they finally analyzed nodule regrowth. And here, sort of surprisingly, they found that compared to conventional surgery, RFA and microwave were superior in over 1,800 patients. But I think you have to read the fine line here. So conventional surgery, as they defined it, was total thyroidectomy, subtotal thyroidectomy, or unilateral lobectomy, all fair to include in the definition, I think. But how did they define nodule regrowth? So for percutaneous techniques, they defined it as an increase in nodular volume greater than 50% compared with the latest sonographic examination for the, again, image-guided procedures. Fair enough. Nodule regrowth for surgery was really when you had a total thyroidectomy or subtotal thyroidectomy. That nodular regrowth was defined as any additional tissue arising from the residual tissue. Fair enough. But for patients who had undergone surgical lobectomy, also included in the definition of nodular regrowth was the appearance of any newly formed nodules on the contralateral lobe. So as a surgeon, I'm highly offended by that because we can't change the physiology of the disease process. So I think that probably explains why these thermal ablation techniques came out with a higher super score compared to conventional surgery. But I think you need to interpret this result with a grain of salt. Moving on to autonomously functioning thyroid nodules. This remains a very popular indication for thermal ablation. It actually is one of my favorite ones to do when it comes to toxic multinodular craters. But this systematic review that was published in 2019 was one of the first, still probably one of the more comprehensive meta-analyses on this topic. And what they were able to show was that in terms of achieving VRR, you can achieve the same, equivalent, or even sometimes better VRR of toxic nodules, because often these nodules are smaller than your non-functioning ones. But when it came to the other goal of treatment, which was achieving euthyroidism and actually maintaining euthyroidism, it was not as good, especially as the nodule, baseline nodule volume increased greater than 20 cc's. So because of this data, when the European Thyroid Association issued their guidelines on the management of thyroid nodules back in 2020, they did not recommend thermal ablation as a first-line option of treatment for toxic nodules. So you can use it, many people do, but you gotta be able to counsel the patients fully, transparently, that the second goal, probably perhaps more arguably the more important goal of achieving euthyroidism, is it mitigated when you use thermal ablation. More recently, this was a systematic comparative meta-analysis comparing radioactive iodine ablation and radiofrequency ablation. And they included many different studies, but really only 3 of them had a direct comparison between RAI and RFA. And what they found was that RAI was superior to RFA in achieving remission. So RAI had a failure rate of 15% compared to RFA with a failure rate of 32%. I will also say, though, that the definition of success, or their outcome that was defined here, was euthyroidism or hypothyroidism. And I would argue that perhaps the better definition is achievement of euthyroidism. Because if you would accept hypothyroidism, why not have surgery? So I think if you defined it correctly, but if we were to consider the outcome to be euthyroidism, the discordance between RAI and RFA would actually not be so strong. So this is our experience at Columbia with autonomously functioning thyroid nodules. We hope to get this published actually within the next few weeks. But we have done about 40-something patients at this point in time. And our remission rate is 87.5%, so a little bit higher actually than I would say is in the literature. Those that have had persistent or recurrent disease have remained subclinically hyperthyroid, and so all of them have chosen to continue observation and not pursue further treatment at this time. You can see from the right side that our volume VRR is actually, again, equivalent, if not slightly superior to our non-functional nodules. Okay, moving on to quality of life measures. This was one of the earlier studies looking at this question published in Spectroscopy in 2021 from Korea. They included 95 nodules and 95 consecutive patients and evaluated quality of life scores across 13 different domains in patients that had undergone a percutaneous ablative treatment, which included ethanol ablation or radiofrequency ablation. And what they found was improvement across all 13 domains of quality of life. We followed that up with a preliminary study in the United States that I think is already published, at least online, in 46 patients that had undergone thermal ablation or RFA for benign thyroid nodules, and we had them do a baseline Thyroid 39 score and compared it to their scores at 3 months and then long-term follow-up, which was a little bit more inconsistent at 6 and 12 months. And you can see that just from the radar plot here that there was significant improvement across multiple domains noted at 3 months follow-up and durable up to the last follow-up, specifically in the domains of goiter symptoms, hypothyroid symptoms, anxiety, cosmesis, and then overall quality of life. So in summary, thermal ablative procedures are safe and efficacious treatment options for non-functional benign thyroid nodules. They do result in excellent volume reduction, which is the primary purpose of the treatments. It is associated with less local complications or recurrent laryngeal nerve injuries than conventional surgery or thyroidectomy. And it can be used to treat autonomously functioning thyroid nodules, but it is less efficacious than thyroidectomy or RAI. And it does improve quality of life and related thyroid patient outcomes for our patients. Thank you.
Any questions? Okay. next speaker will be Dr. Glenn Campbell from Tulane University. We'll be talking about important complications and prevention.